So for today, it gives me grand pleasure to introduce Kelly Roszko, who will be coming to us from the NIH to be talking about targeting the calcium sensing receptor. I have a couple of my first patients with this, so I am particularly so pleased that we got her on board just in time to help me. And welcome, Kelly, and go for it.
Great, thank you. All right, let's share screen. All right, great. You can see the screen? Yeah, wonderful. All right, great. Well, thank you so much for having me here today. I'm really excited to be part of this ECHO series. And as you heard, I'll be speaking today on targeting the calcium sensing receptor. So these are my disclosures, and of note, I will be speaking about Encaleret, which is currently under clinical development, and its safety and efficacy has not been evaluated by any regulatory authorities. So this will be research results that I'll be showing you today. So as far as an outline for today's talk, I will start by talking about calcium sensing receptor physiology and include the effects of calcilytics and calcimimetics on mineral homeostasis. I'm then going to take a deep dive and go into the characteristics of autosomal dominant hypocalcemia type 1, or ADH1. And ADH1 is caused by gain of function variants in the calcium sensing receptor, so we'll be talking more about that. And finally, I'm going to review data that supports the role of calcilytics in the treatment of ADH1 and in post-surgical hypoparathyroidism. And there you'll be seeing some really new research results. So, as many of you here know, the parathyroid glands regulate serum calcium through the action of PTH on the bone. There it acts to release calcium from the bone, and it also acts at the kidney, where PTH causes calcium to be withheld from the urine. PTH also increases the absorption of calcium in the gut indirectly by increasing the hydroxylation of vitamin D into its active form. And that active form is 1,25-dihydroxyvitamin D. So taken together, these are all mechanisms by which PTH can increase serum calcium. And the calcium sensing receptor that we'll speak about today is located on the parathyroid glands and here on the kidneys. And in these places, it senses and signals the amount of calcium present to the organs. Of note, calcium sensing receptor is actually expressed on many other places through the body, but today I'll be just focusing on the parathyroid glands, the kidney, and the calcium effects of the calcium sensing receptor. So the calcium sensing receptor itself forms a homodimer, and it has multiple calcium binding sites, and those are represented in this diagram by those red ovals. It signals via multiple signaling pathways, and these include GQ11, beta-arrestin, and GIGO. So signaling by the calcium sensing receptor decreases PTH with increasing concentration of calcium. And this acts in a really steep dose response curve. And you can see that here with the PTH response on the y-axis and the ionized calcium here on the x-axis. So you can see that very small changes in serum calcium are going to lead to these large changes in PTH. And that ultimately is going to keep the blood calcium in a very narrow and physiologic range. So in this figure here, you can see this blue line, which is representing the serum calcium, is kept very, very stable in a stable range, while the green line that represents the PTH is going up and down to sort of maintain that nice stable blood calcium. So another graph here, which shows the urine calcium excretion on the y-axis and the serum calcium on the x-axis. And you can see very similarly, as the serum calcium increases, the urinary excretion of calcium is also increasing exponentially. So by these ways, the calcium sensing receptor is really helping to signal and keep blood calcium in a really tight physiologic range. So in summary, in high calcium states, increased calcium sensing receptor activity in the parathyroid glands is going to lead to decreased secretion of PTH, which decreases blood calcium. And in the renal tubule, high calcium detected by the calcium sensing receptor is going to lead to decreased calcium reabsorption to rid the body of that excess calcium. So there are primarily two diseases that we frequently speak about of the calcium sensing receptor. The first that I'll talk about is loss of function variance in the calcium sensing receptor. And these cause a disease known as familial hypocalciuric hypercalcemia, or FHH. So in FHH, there's a loss of function variant that causes the calcium sensing receptor to think the blood calcium is low, and therefore it's signaling to increase the blood calcium. So this results in a dose response curve that you can see here that is shifted to the right. So these patients have a set point which is asking for a higher PTH, and they thus have a higher blood calcium and actually a low calcium level because of that set point change. So in many ways, I like to think of this as the opposite disease, and these are caused by gain of function variants in the calcium sensing receptor. And this disorder is called autosomal dominant hypocalcemia type 1, or ADH1. In ADH1, the dose response curve is shifted the other way here to the left. So here, the calcium sensing receptor thinks that the blood calcium is high when it's really not. So it therefore is maintaining the PTH at a very low level, despite the fact that the serum calcium is already low. And so these patients are going to present with low PTH or hypoparathyroidism, low blood calcium. And additionally, in these patients, the calcium sensing receptor at the kidney, it thinks that the calcium is high. So more calcium is actually getting excreted in the urine, and that's going to cause hypercalciuria or high urine calcium. So I put this diagram up. It's a little complex, but really I just hope to show that calcium sensing receptor signaling is quite complicated with multiple components. So I mentioned that this signaling pathway includes GQ11, GIGO, and beta arrestin, all up here. And I show these pathways to illustrate that that variance at different places within the pathway can cause FHH or ADH1 by inactivating or activating the system. So as we've just spoke about, loss and gain of function mutations of the calcium sensing receptor itself can lead to FHH1 and FHH2 respectively. Additionally, there can be loss or gain of function mutations in G-alpha 11 subunit, and these are associated with FHH2 and ADH2 respectively. And furthermore, there's a loss of function mutations that have been described at AP2 subunit that are associated with FHH3. Additionally, we've been able to create synthetic positive allosteric modulators, or PAMs, and negative allosteric modulators, or NAMs, which bind to the calcium sensing receptor transmembrane domain, as you can see here. So let's dive a little deeper. What are these positive and negative allosteric modulators that I just mentioned? So first, there are calcimimetics. These are agonists of the calcium sensing receptor, and they're going to shift this PTH calcium curve to the left. See, so you're shifting back toward normal. And next, there are the calcilytics, and these are antagonists to the calcium sensing receptor, and they're going to be shifting this PTH calcium curve to the right. So you can see that each of these compounds is shifting the dose response curve back toward normal. And these are the first described agonists and antagonists here by a company called NPS Pharmaceuticals, and Ed Nemeth, who has worked closely with us in some of the studies that I'll describe going forward. Okay, so that is a bit about the calcium sensing receptor physiology. And now, as I said, I'd like to go into the characteristics of autosomal dominant hypocalcemia type 1, or ADH1, caused by those gain of function variants. So as I said, this will be a deep dive, and I want to describe some of these clinical features and the presentation of this disorder. So to review and summarize, heterozygous activating variants in the calcium sensing receptor cause this rare form of genetic hypoparathyroidism, which is called ADH1. These variants increase tissue sensitivity to extracellular calcium, shifting that calcium responsivity curve in the parathyroids and the kidneys to the left. This is tricking the organs into thinking that the blood calcium is higher than it actually is, and thus they're trying to maintain that blood calcium at a lower set point. And as a result, patients with ADH1 have hypoparathyroidism, decreased blood calcium, and increased urine calcium. So importantly, the hypercalciuria is often worse in ADH1 compared with other forms of hypoparathyroidism. And this is because these patients have both decreased PTH and altered calcium sensing in the kidneys. So it's kind of two things causing that. The clinical manifestations of ADH1 include symptomatic hypocalcemia, which can manifest as hypocalcemic seizures, paresthesias, tetany, and muscle cramps. Additionally, patients can also have complications of hypercalciuria, and those include nephrolithiasis, nephrocalcinosis, and chronic kidney disease. So, as you can see, it's important to maintain this balance between blood and urinary calcium, and it's very difficult in these patients. Conventional therapy with calcium and activated vitamin D doesn't correct this underlying pathophysiology, and it can actually worsen renal complications because you're creating an increased calcium load coming to the kidneys. So we did know that the phenotype of ADH1 is quite variable, and that some patients present with really severe symptoms while others are essentially asymptomatic. Since ADH1 is quite rare, in order to expand our knowledge on the pathophysiology, the disease burden, and the effects of treatment in patients with ADH1, we embarked on a literature search to characterize the disorder and to try to understand some of these long-term complications. So this was the literature search we did. We used the following search terms here: a date range of 1996 to 2021, and we came up with 70 papers that were used in our literature search. So we ultimately identified 338 patients. Unfortunately, 147 of these were excluded right off the bat just due to inadequate information that couldn't be used for our analysis. And we then divided the patients into cohort 1. This was 191 patients that had information on this, the age and symptom onset, describing how the disorder came to be. Cohort 2 consisted of 91 patients, and these were patients who had information about their clinical presentation. So they were also going to have symptoms as well as pre-treatment blood and urine calcium, blood phosphate levels, and PTH. And cohort 3 contained 57 patients, and these were patients that had information while they were on treatment. So they were going to have pre-treatment blood calciums and then on-treatment outcomes such as blood and urine and information about the complications that these patients underwent. So among those 338 cases that we found in the literature search, there were 113 different calcium sensing receptor gain of function variants. And of these, 55% were in the extracellular domain, 33% were in the transmembrane domain, and 12% were in the intracellular domain. The most common variant that we found was P221L, which was located in the extracellular domain. Some variants, particularly this one, the A843E, are associated with a very severe phenotype that involved electrolyte wasting and a Barter's type syndrome. So that was very significant. But aside from these few very significant severe presentations, for the other variants, a distinct genotype-phenotype correlation was really not present when looking at all of these patients. We looked at the inheritance and found that 78% of the cases were inherited by an autosomal dominant mechanism and were indeed familial. 19% of the cases were de novo, and 3% of the cases were undefined. Consistent with our thinking that ADH1 has this really varied phenotype, we found that 71% of the patients came to medical attention due to symptoms, while 23% were found through family screening, and 6% of the patients were diagnosed really just by an incidental finding on laboratory studies, so asymptomatic without any issues. Additionally, the age of diagnosis of these patients varied widely. So this is the diagnosis of hypocalcemia in general, and this ranged from birth all the way to age 66, with a median age of diagnosis of age 6. However, the diagnosis of ADH1 itself, so actually knowing that this was a calcium sensing receptor variant, was even further delayed, with an average range of birth all the way up to age 77 and a median age range of 25 years. So we believe that these large delays in diagnoses are likely due to this variation in presentation, where some patients really just have a mild course and they're not diagnosed until later in life. However, aside from that, I think it's important to remember that these ages could be changing in the more recent years, because obviously now it's much easier to get genetic testing and for patients to establish a diagnosis. So we are hoping that we'll see more patients able to do that and establish their diagnosis at a younger age moving forward. So the presenting symptoms varied widely. 27% of these patients were actually asymptomatic. 32% had moderate symptoms. And those were defined as muscle cramps and spasms, bone or joint pain, tetany, paresthesias, brain fog, and fatigue. And 41% of the patients had severe presenting symptoms. And these patients had seizures, loss of consciousness, or laryngospasm. So, of note, the most frequent initial symptom of presentation in the whole cohort was seizure, and that was in 38% of the patients. And I think this further reflects the need to diagnose ADH1 in a more timely manner and to think about that in genetic counseling, and when affected parents are having children. So these are the initial calcium levels from all 91 patients who had calcium values. And not surprisingly, the calcium was significantly lower in these severe ADH1 cases in comparison to the moderate or the asymptomatic cases. So we did see sort of that low trend to a lower calcium in more severe cases. And these are the presenting laboratory studies from those 91 patients. And it's split up into asymptomatic patients in the light purple bar, moderate symptoms in the light blue bar, and the patients with severe symptoms represented by this dark purple bar. And the gray bars here are going to represent as all individuals. So taking all individuals together, you can see that 99% of the patients all had low blood calcium. 59% had high blood phosphate, and 59% had, frankly, low blood PTH. But importantly, you can see here that 35% of these patients had high urine calcium values on their initial study, and this is before any treatment was administered. So they were already hypercalciuric here on presentation. So the majority of cases were treated with active vitamin D alone. And you can see that in the dark purple box. Others were treated with activated vitamin D and calcium, and just a few cases here in the blue were treated with calcium alone. And because treatment increases that blood calcium level, the cases of hypercalciuria increased significantly when patients were treated. So you can see here that 34% of the patients had hypercalciuria before treatment, but after treatment, 66% of those patients had hypercalciuria. So quite a jump there. And so then we wanted to look at complications in these treated patients. And we defined complications as kidney stones, as nephrocalcinosis, and renal insufficiency. And we found that there were complications in 76% of the total ADH1 patients who underwent any treatment. Of note, there were complications in 47% of the patients who had a urine calcium that remained in the normal range, but there were complications in 88% of the patients who had hypercalciuria. So this is showing that this high urine calcium is likely related to increased complications, and it really illustrates how important it is to keep the urine calcium controlled in our patients. So monitoring and really trying to control that urine calcium can likely help with these complications. So here is the summary of what we just described in ADH1 patients. So ADH1 patients had a wide spectrum of symptoms. The average calcium levels were lower in patients with more severe initial symptoms. Treatment can exacerbate hypercalciuria. High urine calcium can be associated with a greater chance of complications. And taken together, this really suggests monitoring and treating hypercalciuria is quite important in these patients. So with that background about ADH1 itself, now I'm going to move forward and describe some of the data supporting the role of calcilytics in the treatment of ADH1 and in the treatment of post-surgical hypoparathyroidism. Okay, so to go back to reviewing those curves quickly, we believe that calcilytic compounds could be a potential treatment for ADH1. And as we discussed, this is because calcilytics are negative allosteric modulators of the calcium sensing receptor that are going to decrease the sensitivity to extracellular calcium. And normalizing this receptor sensitivity could correct the hypocalcemia, the hypercalciuria, and the low PTH in these individuals with ADH1. And this would be by shifting the calcium responsivity curve in the parathyroids and in the kidneys back toward normal. So with this rationale, we had initiated a study of the calcilytic NPSP 795 for ADH1. And here we use 3 different IV doses escalating over 3 days. And you can see the percent change in intact PTH here on the y-axis, and then the PTH level itself here on this y-axis, with the time in minutes below on the x-axis. So on day 1, the patients received a 5 milligram dose over 10 minutes. On day 2, they received 15 milligram dose over 3.5 hours. And on day 3, they received a 30 milligram dose over 3.5 hours. So you can see here that the drug worked and that PTH indeed increased in a dose-dependent manner. So this was very exciting for us as a proof of concept study. So with this knowledge that calcilytics indeed did increase PTH in this dose-dependent manner, we designed a phase 2b study with Encaleret. And Encaleret is an investigational oral calcilytic. And this is Rachel Gaffney, my colleague from the NIH, and she is the leader and PI of these studies. So the study that I'll describe has consisted of a period 1 here, which is an individualized dose escalation. This lasted for 5 days, and the patients, six patients were inpatient during this period. Then there was period 2, and period 2 was an individualized dose titration, which again was inpatient over 5 days. And there were 13 patients enrolled in period 2. These patients then went on to period 3, and period 3 was an outpatient extension for 24 weeks. And the results that I'm going to show you were taken here at the end of phase 2b. The patients were then entered into a long-term extension study as an outpatient and finally into a phase 3 study. So Encaleret was orally administered twice a day and individually titrated to target a normal corrected calcium and phosphate levels. And again, the key objectives were safety and tolerability, blood calcium, urine calcium, and intact parathyroid hormone. So we studied 13 subjects with 9 different variants of the calcium sensing receptor who were enrolled. And at baseline, all of these patients had the typical biochemical features of ADH1. So they had low blood calcium, low PTH, high blood phosphate levels, and inappropriately normal or frankly elevated urine calcium. 3/4 of our patients had renal calcifications on baseline ultrasound, and magnesium was in the low normal range, and 8 patients were on magnesium supplementation. 5 subjects were being managed with calcium and calcitriol supplements here, and fairly usual doses. And 5 of these subjects were taking citrate. And here are the graphs that are going to show the mean response to Encaleret during those 5 inpatient days of period 2 here on the left. So this is the 5 days, and the 24 outpatient weeks of period 3 here on the right side of the graphs. So in the upper panel, you can see hypocalcemia, that's blood calcium on the y-axis, and it corrected by day 2 and then remained in the normal range all throughout during period 3. So this all coincided with a robust PTH response to Encaleret. And you can see that PTH increased from a very, very low mean baseline here to a value well within the normal range as soon as 30 minutes after the first dose of Encaleret. And then on a stable individualized dosage, the mean PTH remained in the normal range during period 3. Concurrently, you can see on the bottom, the mean 24-hour urinary calcium excretion dropped into the normal range within the first 24 hours, and then it remained in the normal range throughout. Additionally, there was no progression of any renal calcifications on ultrasound at 24 weeks. So on Encaleret, the mean blood phosphate level decreased from a high normal level into the mid-normal range. There were a few instances of mild hypophosphatemia that were asymptomatic, transient, and they resolved either spontaneously or with reduction of that Encaleret dose. This decrease in phosphate occurred concurrently with a rapid decrease in tubular reabsorption of phosphate, which is consistent with the increase in PTH levels. And by period 3, with stable Encaleret dosing and normal PTH levels, the blood phosphate and the TRP both remained within the normal range. So Encaleret was well tolerated with very few adverse events and no serious adverse events. The only treatment-related adverse events were these instances of transient hypophosphatemia and mild hypercalcemia. And both of these either resolved spontaneously or within just adjustment of that Encaleret dose. We were very pleased with the safety profile of the drug. So in summary, Encaleret restored mineral homeostasis in 13 individuals with ADH1. This was demonstrated by normalization of the mean PTH, blood and urinary calcium, blood phosphate and magnesium, and 125-dihydroxyvitamin D levels. Encaleret was well tolerated over these 24 weeks with no serious adverse events reported. And now a multi-center phase 3 trial is ongoing. So results for that will come in the future. So now I'd like to pivot the discussion, and I'm going to speak about the potential use of Encaleret in post-surgical hypoparathyroidism. So central to this discussion is the understanding of the relationship between urinary calcium excretion and blood calcium, and that is shown here with calcium excretion on the y-axis and plasma calcium here on the x-axis. And the normal range for blood calcium is in gray, and the normal urine calcium falls below this yellow-green line. So in normal controls, when the blood calcium is in normal range, so is the urinary calcium excretion. So you can see that down here, all in the normal range. However, in patients with hypoparathyroidism, physiology studies have shown that this relationship is shifted to the left due to the loss of PTH. So these patients have a higher urinary calcium excretion at normal blood calcium levels. You can see here. So we hypothesize that Encaleret will be able to shift that relationship between the blood and urine calcium back toward normal to look like this red dotted line that shifts back. So this is one of the 2 preclinical animal studies that supported our rationale for this trial. This is a study by Lupi et al. And this is a study in total parathyroidectomized rats. And it showed that a calcilytic NPS 2143 was able to increase blood calcium, shown here. So this is the NPS 2143 versus the control. And you can see this increase in calcium well on the days of treatment. And additionally, not shown here, this treatment actually also decreased the fractional excretion of calcium independent of PTH in these parathyroidectomized animals. And perhaps the most compelling support for the use of calcilytics in post-surgical hypoparathyroidism derives from mineral physiology studies that were done 40 years ago here at the NIH by Maurice Addy and Jerry Auerbach. So they studied patients who had both familial hypocalciuric hypercalcemia, or FHH, and post-surgical hypoparathyroidism. As we discussed earlier, FHH is caused by those loss of function variants in the calcium sensing receptor, and it's thus the opposite of ADH1. So, in a way, FHH could be like a normal person on Encaleret. So, if you take a person with FHH and post-surgical hypoparathyroidism, it could mimic a person with post-surgical hypoparathyroidism on Encaleret. So, indeed, these patients with hypoparathyroidism and FHH did maintain a low calcium excretion even at normal or moderately high blood calcium levels. And you can see those patients are here in the green. Um, and based on this relationship, these patients were actually shifted farther to the left than the normal line here. So, we speculate that the calcilytic and post-surgical hypoparathyroidism will have a similar impact on urinary calcium excretion. And these promising findings encouraged us to go ahead and pursue a clinical trial to further understand the actual human physiology in this disorder. So this is a trial of Encaleret in post-surgical hypoparathyroidism. It is led by Dr. Iris Hartley, who is my colleague here at the NIH. And we plan to enroll up to 15 adults with post-surgical hypoparathyroidism. So this is an open label study. It's a proof of principle design. The patients are given 5 days of Encaleret at 162 milligrams twice a day. So this is a very high dose, but the high dose was chosen to really try to optimize our ability to see an effect. And during those 5 inpatient days, the patients underwent serial blood and urine sampling throughout the trial. So this is what the setup looked like. The patients were admitted the day prior to starting the drug to the NIH Clinical Center. They have to stop their calcitriol and calcium, and they're then started on a fixed calcium and dietary calcium regimen. They were only receiving additional rescue calcium or calcitriol if they had increased symptoms of hypocalcemia. Otherwise, they didn't receive calcitriol to allow for us to see if Encaleret has an impact on the alpha hydroxylation of vitamin D independent of PTH. And by day 3, we would start calcitriol if a patient remained hypocalcemic, because we did want to allow for an adequate calcium load if needed so that we could see an effect here. So this was the general layout. And after day 5, the patients went back to their standard of care and were discharged from the hospital. So the primary endpoint of this study is the change of the fractional excretion of calcium. The secondary endpoint is the proportion of subjects to achieve a normal blood and 24-hour urine calcium. And there were additional exploratory endpoints here that you can see listed here. So these are the preliminary results. As I said, these are quite preliminary. They're only in 5 patients so far. And this graph is showing the fractional excretion of calcium here on the y-axis and hours after starting Encaleret here on the x-axis. So the bars up here are the patients. 3 of the patients received 4 doses of Encaleret, and 2 of the patients received Encaleret for the entire 5 days. And you can see here that the fractional excretion of calcium decreased significantly and stayed in the normal range well on Encaleret. Additionally, the blood calcium increased well into the normal range, while the fractional excretion of calcium was reduced, despite that the patients all had decreased calcium and calcitriol requirements. And finally, this is the 24-hour urine calcium data. And you can see that the 24-hour urine calcium also decreased into the normal range despite the increased blood calcium levels. So while the patients had much improved blood calciums, their urine calciums did come nicely down into the normal range. So we believe the future here is promising. There is currently this phase 2 trial of Encaleret in post-surgical hypoparathyroidism, which is ongoing. Additionally, the phase 3 trial of Encaleret in ADH1 patients is currently ongoing. And there are several future potential directions for the use of calcilytics, such as a trial in children with ADH1 and a question of the use of calcilytics in other forms of hypoparathyroidism. So I think all of this is in the future, but I will mention that these trials are currently active and recruiting. So if any of you do have patients, we would really love to hear from you, especially if those patients would be interested in participating in one of these trials. So in summary, the calcium sensing receptor is key to the regulation of calcium homeostasis in the parathyroid glands and in the kidneys. Loss of function variants in the calcium sensing receptor cause familial hypocalciuric hypercalcemia, or FHH. Gain of function variants in the calcium sensing receptor cause autosomal dominant hypocalcemia type 1, or ADH1. In a phase 2 trial, Encaleret, this investigational oral calcilytic agent, was able to restore mineral homeostasis as seen by normalization of the blood calcium and PTH levels in patients with ADH1. And then I showed you preliminary results, which support the continued evaluation of Encaleret as an orally administered therapy for the treatment of patients with post-surgical hypoparathyroidism. And as I said, those studies are ongoing.